Thank you, Dr. Sujitra. I welcome you all to this wonderful session. So without further delay, let me go into my topic. So the topic is regarding identity and scope of family medicine. So first of all, let me welcome you all to your postgraduate journey. Those who are new here, welcome to this branch. It is one of the most fulfilling branch that happen to you. So this is going to be a really good journey. So defining the identity of a family medicine specialist. So a family medicine specialist is the ultimate generalist. That is, he or she has the professional responsibility for unselected patients with undifferentiated problems. And it is mostly focused entirely on the whole patient and not just the disease. And the family physician is the first point of contact who can manage around 80 to 90% of all health conditions in a community. So thereby providing holistic and comprehensive care to the patient. So these are the pillars of family medicine. You will have a detailed session later. So the pillars are comprehensive care, continuous care, coordinated care, contextual or family-oriented care, and preventive care. So for example, you are able to manage the symptoms of the patient. You are able to manage their chronic diseases like diabetes, hypertension. You are able to coordinate their care with their subspecialist. You are able to advise their family, give family counseling. And most importantly, you are also able to advise on the preventive care. Suppose a patient whose father has a history of CA colon, you can advise the patient that after the age of 40, 50, he has to do a screening colonoscopy. Likewise, a patient with family history of breast cancer, a female, you can ask them to go for a mammogram. So there are so many things that a family physician can do, and it's a privilege. So coming to the Indian healthcare and medical ecosystem, the healthcare dilemma in India is that the care is really fragmented. We all know that patients are now over-consulting subspecialists for minor common health issues. There is this rising healthcare cost giving rise to a lot of high out-of-the-pocket cost for unnecessary investigations. Suppose you are going to a subspecialist. Suppose, for the example, the most common example that we give is that of a headache. You're going to a neurologist for your headache, and the neurologist has definitely got to rule out the neurological causes. And he may order a CT or MRI. And so this will, cost you a lot. And this reports may be normal and the investigations may be unnecessary. And now there is this dual burden of managing both infectious diseases, and there is an explosion of chronic lifestyle illnesses in our healthcare system now. So the National Health Mission and the National Medical Commission are prioritizing family medicine for universal health coverage. Okay, so coming to the scope of practice or the clinical horizons. So a family physician can very easily manage the common infectious diseases, the non-communicable diseases or the lifestyle diseases, then common emergencies. They can manage the common problems that women face, then antenatal checkups, immunizations, newborn care. In my residency, I still remember there was a patient who was diagnosed to be pregnant in our family medicine OPD by my HOD, Dr. Rishmi. And that patient wanted her antenatal checkups to be done by a family physician. And so throughout the journey of her pregnancy, we advised her regarding blood test, antenatal checkups, immunization. And finally, in spite of being a tertiary care hospital, it was a family physician who managed her. And only towards the end of the pregnancy, we actually, referred her to the gynec department for safe confinement. So that is the power of a family physician. Now, care of children, we can manage the common ailments. We can do minor surgical procedures like wound care, excisions, foreign body removals, fracture reduction, take care of the mental health. And geriatric care and palliative care can also come under our care. And I would advise doing some kind of add-on courses after your post-graduation to broaden your knowledge in those topics. Most of these courses are not MCI recognized, but it will definitely help you in enriching your knowledge, especially if you're catering to this group of population. Now, coming to career pathways. So a family physician can easily have a private clinic, can head community polyclinics, be medical officers and chief medical doctor in peripheral medical centers of tertiary care hospitals. So here there is the ultimate clinical autonomy and high community impact. And in corporate and metros, we can have our own OPDs. We can give evidence-based preventive health checkups, home care services, geriatric and palliative care services. So here it is a highly collaborative network, and mostly the hours are all fixed and very stable. And in academics and public health, after doing 1 year of senior residency in medical colleges, you can be assistant professors, and also you can be teaching faculty or academic coordinators in family medicine institutes, project managers, etc. You can lead research and shape national health policy. Now, digital age is also the new thing. There are telemedicine networks. You can do remote triage platforms, and there is this borderless patient reach here. Now, this is just a snapshot regarding the current situation in our country. You can see that there are 68 DNB family medicine institutes, 33 institutes having secondary DNB, 108 diploma institutes, 8 MDFM seats, 6 AIMS institutes having 16 seats, and totally the current number of students is around 1,254. And our community is continuing to grow. So another most important question that every family, every person who has taken family medicine has faced is, what is the difference between MBBS and family medicine? When I joined my residency also, on the first day itself, the medical director asked me, why did you choose family medicine? What is the difference between family medicine and an MBBS doctor? So I would say that at that time, I didn't have much of an idea. I told him I like all the specialties, that why I chose family medicine. But now I have a better idea. So the MBBS is actually just a basic entry level undergraduate degree, whereas family medicine is an advanced 2 to 3 years postgraduate specialization where you have, you work just like any other PG in the subspecialties and gain the enough knowledge to practice. And coming to the depth of practice, an MBBS graduate is able to offer episodic care. Symptoms are addressed individually. And here also the tertiary care exposure is more, whereas the primary care exposure is actually comparatively less. Whereas a family medicine specialist is trained to give continuous lifespan care and can handle comorbidities and give patient-centered care. MBBS graduates will be quick to refer complex multi-system cases, whereas a family physician can resolve up to 90% of all clinical presentations. The key clinical skills for MBBS include giving standard first aid, general triage, and basic diagnosis, whereas advanced multi-specialty triage and minor surgical procedures can be done by the FM. And the scope of view, organ or pathology focused perspective, whereas in family medicine, it is contextual, family and community centered. So while MBBS degree provide a basic foundational level of medical education, your postgraduate specialization gives you the depth to independently, resolve cases without immediately relying on subspecialist. So MBBS is usually limited to institutional medical officers, primary healthcare centers, or they just act as a bridge before chasing a post-graduation seat. Whereas family medicines doctors are positioned as expert consultants in corporate hospitals, they are leaders of community polyclinics, faculty in medical colleges, or pioneers in telemedicine networks. So now coming to common myths and reality. Myth 1, family medicine is just extended MBBS. Of course not. It requires 36 months of intensive rotatory residency across critical specialties. So we learn more in depth about that specialty along with imbibing the principles of family medicine and patient-centered care. And like any other postgraduate resident, we also have to submit our professional thesis and undergo medical board examinations. Now, the second myth is that they are only OPD doctors. Reality is that they are highly trained. We are highly trained to recognize acute emergencies, coordinate complex inpatient transitions, and manage intensive palliative care regimens. And the third myth is that there is no academic growth prospects. Of course not. I just gave you all the data. Rapidly expanding national healthcare policies have opened major pathways to become assistant professors, clinical directors, and policy administrators. So the National Medical Commission, the NMC, officially prioritizes and protects the development of family medicine across India. So the legal framework mandates the Undergraduate Medical Education Board to prioritize family medicine and primary healthcare delivery, and orders the Postgraduate Medical Education Board to facilitate and heavily scale postgraduate seats in family medicine. So these are the 7 expert roles outlined by NMC. The family medicine specialist is a clinician providing comprehensive whole body medicine, a leader who effectively organizes and heads multidisciplinary clinical teams, a communicator building empathetic long-term patient relationships, a collaborator, scholar, professional, and social advocate. The Indian government and NMC explicitly recognize that our current health infrastructure is over-reliant on tertiary subspecialties, and as a result, it has legally institutionalized family medicine to create doctors who can manage resources and drive public health advocacy efficiently. So be proud that you have taken family medicine. It's a very beautiful branch. It is a lifelong journey, and I wish you all success. Thank you.